get to forward them, right?
No, you don't
So
get
we
to
have a
forward
set
them.
of we have a set of questions that are more oriented towards potential next steps for this group and or other related groups. And I think we don't have nearly enough time to actually discuss all of these, but we're going to do the best we can. So the IOM, are you going to read the question?
Yes, the IOM should create a forum for health professionals, patients, and other key stakeholders to begin creating an explicit shared social contract for the health professions.
Note that we put the S on there because we're not assuming that that everyone in the room is convinced that there is a unified health profession. So that diagram that Pat Werhane put up, that's not here. We're not there yet. So we have a plurality who are neutral or unsure, 6 who strongly disagree, sorry, 2 who strongly disagree, and then the remainder who either agree or strongly agree. Does anyone want to say why they're either in the disagree or the neutral unsure category?
I'll admit to being in a disagree, strongly disagree.
Yeah.
And I'll also admit that I'm naive to really what it takes to construct a social contract that would be meaningful at the level of community or individual patient or provider. I simply can't imagine that it could be done by an institute of medicine and have it translate down to real time where it needs to happen. And therefore, I think that's where it needs to be created.
So I would like to probe that a little more because I think this begs the question that we've been kind of dancing around the entire time of who would have the capacity to bring together the stakeholders. We talked a little about the Tavistock meeting, which was a terrific meeting of very high-level people from a lot of different organizations, and all they were able really to accomplish was a set of shared principles which never had legs.
Yeah, and I think that that's the problem. I think we could get together here and talk about this a lot. I think that this report will inform a lot of people who haven't thought about this before, myself included. You know, but I think about a group of people who have a common concern, and maybe let's talk about people who have Alzheimer's. Mm-hmm. You bring a group of caregivers and clinicians and others who are the stakeholders around navigating that set of diseases into a conversation about how could that care be better. Mm-hmm. And I think you could come up with some language, and I think you could come up with some material that would help local caregivers create a social contract in the context of their care and social service delivery system that I think might really benefit everybody in the game. But I think that can only be stimulated at a national or at an international level. I think it has to drill down a lot more locally than that.
A lot more context would be necessary. Yeah. I don't know what I just did.
I was the other person. I was the other person and strongly disagree for 2 to 3 reasons. One, I think when we're really talking about a social contract, I'm not sure, again, similar to Lucinda, that first of all, the IOM would be the right person right group because we have such an uneven system now. And it goes back to my question yesterday about whether if we were to ask society, patients, whatever that other group is that we are going to contract with, if that word is even relevant to them, or is it more that covenant? Are there other terms? And so I'm merely thinking it needs to start with the people that we think we want to contract with, and maybe they would describe it very, very differently.
Sally?
I was sort of on the unsure, on the fence here, partly because I believe the conversation needs to begin, and the IOM is a place where a conversation can begin. And I think there's a lot of power there and opportunity for that conversation to get some legs, as you say. But I also, I'm concerned because I don't think there's, as was just said, equitable distribution of representation that I think would need to be there. And then the other concern I have is there needs to be money on the table. There needs to be something to fund this, because you can't expect people who are caregiving, who are in, they're not in situations to volunteer their time. So we need to be careful about what our expectations are and how we're setting those expectations. And the IOM model is many of us come and volunteer our time to do these kinds of things. So I'm on the fence. However, I do feel the conversation needs to begin, and this is a place to begin it, to figure out what would give it legs, and who needs to be at that table to start giving it legs, and then how do we get them here, but also support them in their being here.
Here's an off-the-wall suggestion that I have no brief for, but how about consumer reports as a place to begin this conversation? They're interested in health, increasingly so.
Yeah.
It is the public's voice, a respected group, I think. I don't know much about it, but it occurs to me that sort of gets us out of this dilemma of where within the professions this might be located, and really gets the public sort of as the focus. So just a thought.
It's an interesting thought, and as you probably know, they're involved in the Roundtable on Science and Value-Based Care, which also has a project very closely related to this work on team-based care and the principles and values of team-based care, as well as a project that Sally is leading up on the patient's role on healthcare teams, which again touches on very similar thematic elements. You want to say one thing, and then we probably should move to the next thing, but go ahead.
I was just going to say quickly that the money is with the health systems. And so if you're going to go where the money is, which I think is a wise thing to do, there are health systems who are interested in this. Mm-hmm. There are big health systems, there are smaller health systems, but I think on the table there are many examples of health systems who have invested in these things, these types of things. I just don't think they're quite aware of the language and the concepts. So if we could marry the language and the concepts from the IOM type discussion forum to those who control the resources, it may be that several of them would be interested in doing something.
You know, what I like about that and the Consumer Reports thing personally is these entities also understand innovation. And one of the things that's been sort of a subtext to some of our conversation that I don't know we've quite articulated yet is there can be a tension between focus grouping something and innovating something, right? There's a famous quote, not actually by Henry Ford, but if I'd asked people what they wanted, they would have said a faster horse. Or Steve Jobs, also famously said something about people don't know what they want until you show it to them. And this is an important aspect of the innovative process. But it's also the case that Ford lost a lot of market share because he failed to listen to what was going on in the marketplace, right? General Motors was able to become very successful by offering people multiple colors of cars, whereas Ford said they can have any color they want as long as it's black. So there has to be a balance between the sort of innovative, entrepreneurial, creative aspect of health system change and consumer patient / input. Doug, you're like, I gotta say something.
I was just going to suggest that maybe we ought to model what we're talking about in terms of transdisciplinary and talk to these other groups, and particularly the ones that you mentioned that already have some of these conversations underway, and see whether there could be a collaboration around these conversations. And then eventually, the reason that I voted agree is that I think, well, it could be a consensus statement ultimately that is promulgated by multiple groups, including the IOM, as one that has a lot of gravitas within policy world, but also Consumer Reports, which very much has can express the voice of the average person. If each of them issues it as a consensus statement, then it could be a broader consensus will be obtained.
I think all we can do is I think all the IOM within this type of forum can do is issue discussion points, not consensus statements. But, Maddie.
I think if we're going to do that, it parallels a conversation that we had in our small group earlier in the session yesterday, which was we got all involved in discussing health disparities, and somebody said, well, there's a whole IOM committee on that. And I think we need to remember the name of our forum, which is Innovations in Health Professions Education. So we would want to invite others to speak to how what they're doing should impact innovations in education.
And in point of fact, the reason we put this particular question up was to spark thinking about a forum outside of the Global Forum on Innovations in Health Professions Education, because it's related to the work that's going on here, but it's not exclusive to the work that's going on here. So this would be a different forum, whether global or national, international, I don't know. But the thinking was, is there interest in this, conversation, getting the conversation started, as Sally put it.
But I also think there's a case for bringing those voices into the context of educational reform.
Let's go to the next, we could probably talk about any one of these items, the entire. Organizational competencies should be developed to assess whether organizations are creating practice climates that support this hypothesized shared social contract. So this is separate from teaching competencies for students. It should organizations be looking at their environment and whether it supports the notion of a shared contract, trustworthiness across all the professions. Wow, a lot more agreement here. Maybe because it's easier to tell other people what to do than it is to. So yes, organizations, they definitely should do this. Any comments on this? No, we're just all in agreement. Organizations should do this.
Oh, well, it's Richard Murray, I'll offer something. Look, I think this is really the key point, because there's a lot of, and we were talking earlier on, there's a lot of talk about the need for things that are based upon engagement and ethical behaviour and teamwork and so on. But unless that gets traction by reform and attention to structures that enable, then it's hot air. Then it's kumbaya. So I just really, this question of how you set up structures within organisations that engage, that institutionalise engagement and reflection, that provide opportunities for authentic partnerships rather than rhetoric. I think this is the key. And as you can't prescribe it centrally, but you can describe the models and you can enable things centrally, so that at least there's not a, at our distributed healthcare management level, where the rubber hits the road, there is an opportunity for people to think differently about how they are allowed to, and indeed encouraged to, build authentic partnerships with community stakeholders.
It begs the question about who's going to do this.
Right. Well, this is because any assessment program is by necessity built off of a set of standards of some kind. Articulated standards have to be in existence before you can start assessing according to those standards. Yeah.
I'd be curious if that question could be posed once again and organizational representatives respond to it.
So only people who might actually be able to do an assessment within an organization?
Yeah, curious.
That's a technical question. Hunter, did you hear the question? Can we redo a question? Okay, so the rule now, Marla, is only if you are in a position to actually do such an assessment within an organization, may you answer. If this is only hypothetical to you, leave your clicker on the table. And I suspect we're done. For those, let's assume that a couple people said yes. Does this mean, if I can get one of you to pipe up. Does this mean you're already doing some kind of an assessment like this, a team-based, are we creating an environment that supports team-based care? Is that what you're going to?
Well, not very well, but are we doing it? Yes. I think Eric can speak to that probably more elegantly than I can, but in the VA we are doing it, and I think a number of organizations are doing it, trying to do it. We need a lot more effort, a lot more resources, a lot more thought, frankly, about how to do it well. But I think this is increasingly recognized by organizational leaders as a critical effort. I think the leadership of the ACGME understands this. Their new accreditation system is predicated on getting measurements of the learning environment, so to speak, in a generic way, and other accreditation bodies are equally moving in that direction. So I think this is a movement whose time has come, but we don't know how to do it well.
Okay, Eric, and then we're going to do the last two questions, which are related, so maybe we'll just do them in a row. And then
Just real quickly, I mean, there are a number of tools to look at the quality environment. I mean, there's the safety tools, there's certainly learning environment tools. They tend not to focus exclusively or well on the social contract piece. They do tend to focus on the environment, how it is to work and respect and that sort of thing. So I think that's another piece that's kind of missing. But, I just call out the ACGME has the clear visits. That is a receptor site to build some of this in, at least within medical training. I'm sure some of the other accrediting bodies, that may be an opportunity as well.
Yeah, the notion of a social contract in the sense of explicit and implicit expectations are implicit to those kinds of assessment tools, right? The reason why we do this is so that we will be trustworthy. So let's just do the last two questions. We'll do these in a row, and then we have about a minute for conversation. Individual practitioners should be allowed to opt out of the shared social contract as long as they disclose this to patients or customers. So if you want to say, I am not a doctor in the way you think of doctors normally. I'm a doctor who is paid by the insurance company and I have their best interests at heart. Mostly I'll do what's good for you, but if it comes to real conflict, I'm going to look to the well-being of the corporate person who's paying me. Well, as long as you're honest. This is, by the way, this is a real, truth in advertising. There's a terrific article about this, by the way, called Dr. Schmachter. No, you can vote. Oh, sorry. If you may not vote now. Yeah, we have to vote on each of them individually, right? So that was number one. An individual practitioner should be able to opt out of the social contract. Okay, question two. A health profession should be allowed to opt out of the shared social contract as long as they disclose this to potential customers. So if you are in whatever group you want to be in, and you say, you know what, that thing that the IOM was talking about or that the Tavistock principles, they don't actually apply to us. Wow. Not very American.
Really?
Maybe you're not a health profession if you opt out.
Right, I suppose so. You'd be defining yourself out of the health professions. You'd be saying, I'm something else.
Yes, especially if health professions are defined as having a social contract.
As having this shared social contract.
I mean, we're in a kind of a circular argument here. Yeah.
Okay, I think we're done with our time. Thank you so much.
Thank you. Thank you. And I just wanted to say one more thing before we move on to the next part of the program, and that's we know that we were going to raise more questions than answer in this forum, and we know that there were going to be a lot of different interpretations and discussions of the language and the words. But if you take something away from this, what I'd like you to do is just take a few minutes yourself and think about what it is you're going to take away and what it is you're going to take back to the organization that you represent, because everybody in this room has a very significant leadership role in different organizations, and it would be very important, I think, to try to think about What is it you want to take back to your home organization from this conference? Thank you.